I would like to please welcome Maria Judd.
Thanks very much, Matt, and thanks everyone for being here this morning. It's really a privilege to be here with my fellow panelists, and I'll just take a moment to introduce them. Dr. Ross Baker, who's a professor here in Toronto at the University of Toronto. Patricia O'Connor, who is a clinical improvement advisor and faculty for the Canadian Foundation for Healthcare Improvement, CFHI, and former director of nursing at the McGill University Health Centre in Montreal. And Dr. Petrina McGrath, who's the VP of People, Practice and Quality at the Saskatoon Health Region. Just wanted to get a sense of who's in the room with us this morning, and we all wear many hats. But if you could think about maybe the primary hat you put on this morning in coming here, we'd like to get a sense of who's in the room as a healthcare executive or an administrator, as a researcher, as a clinician, or as really, we're all patients and families, but if you're here with your patient and family perspective this morning. So just a show of hands, those who are here as healthcare executives or administrators. Great. People who are primarily here with their research hat on this morning. Welcome. Someone who's primarily as a clinician. Fantastic. And anyone here is sort of a patient family advisor hat on. Welcome, we're so glad you're here. So thank you all for being here, and everyone is important for creating what we call engagement-capable environments, which are key for making sure that patient engagement is meaningful and actually translates into innovation and improvement. You're going to hear more about that from my fellow panelists this morning. So did you know you were at a book launch this morning? We're here to share with you some of the cases that we've compiled and made part of this book that we are launching today officially. It came out of joint work that was really co-created by Dr. Ross Baker and his research team and CFHI staff at the Foundation. In 2015, we were asked by the Federal Innovation Panel, chaired by Dr. Naylor, to help them identify effective patient engagement strategies. And we were asked to do that because of the work at the Foundation we've done in working shoulder to shoulder with 40 teams across Canada and supporting and learning from them in their work of engaging patients and families and improving how we design, deliver, and evaluate health services. And also the work we funded, the research project led by Dr. Ross Baker and team, looking at that question really on an international stage. And so this book has really come out of what we submitted to the Federal Advisory Panel, and we're really pleased to share it with you today. So just to highlight, so you're going to have a chance to hear from Patty and Petrina, who are really two leaders of two of the organizations featured in the case studies in the book. And this idea we're going to be talking about creating engagement-capable environments and the key role of leadership, and they're going to share some of their leadership perspectives with you this morning. So this book is really made possible because of the work and investment of the Canadian Foundation for Healthcare Improvement. We are a nonprofit organization, pan-Canadian. We work with teams from across the country, shoulder to shoulder, to help improve health and care for Canadians. We do that by helping to identify innovative models and practices of care and to spread them across the country. Right now, we are working, for example, helping to spread Dr. Samir Sinha's and team's ACE program developed right here in Toronto at Mount Sinai Hospital across the country. And so we brought together through a Quality Improvement Collaborative 18 teams, and we're supporting them in coming together to learn about the model and how it can be adapted and implemented in their local context, who are the stakeholders and partners who need to be involved. And we provide support through education, coaching, evaluation support, and seed funding for that implementation and change initiative. And really central to how we work across all our programs is engaging those who experience care and need care as experts in improvement and in co-designing improvements in care. And so we're really here to talk about what we've been learning with organizations in 3 countries that are profiled here today, and the voice of leaders about what we know that patient engagement is truly a lever for healthcare improvement and for transformation. And we look forward to your questions and comments at the end as well. So without further ado, I'd like to turn the podium over to Ross Baker.
Thank you, Maria. It's It's a great privilege and a pleasure to be here today, and I look forward to engaging with you on this topic, which I think many people are interested in today because they see patient engagement as a critical piece of the continuing reform and improvement of our healthcare system. As Maria said, this project has been several years in the making, and this is really the first of a series of things that we see coming from this as we drill down on the research that we did over several years. And I worked in collaboration with Jean-Louis Denis and Marie-Pascale Cornet in Montreal, and Yvonne Bombard and Annie McIntosh-Murray here in Toronto, and Jocelyn Cornwell in London, as we did a series of case studies and a review of the literature and a variety of other projects in this area. The critical issue now around patient engagement is not whether this is an important issue, an important strategy for the healthcare system. The important issue is how we do it in a way that gets beyond the sort of notional tick box exercises to say, do we have patients involved? How do we make this meaningful and impactful in the healthcare system? And so what we're going to do today is talk about some of the learning that we had in this series of case studies, some of which were developed originally for the research project and some of which we added in the development of this report for David Naylor and his colleagues at the Innovation Panel. And I'm going to start with this diagram, which I find very helpful because patient engagement is one of those omnibus terms. People mean different things when they say this. So this diagram comes from an article by Kristen Carmen and some colleagues published in Health Affairs a few years ago. And Carmen and colleagues say that we can think about engagement at three levels. We can think about it, first of all, at the direct care level, which is the level that most of us experience and most of us think about, because that's the direct influences on the choices we make as individuals, as patients, as family members. And as you think about the direct care level, you think about this continuum that goes from simple consultation, when you're asked what your views are in terms of the treatments you're going to receive, and then involvement, where you're truly given a set of options and information that help you choose the treatment, the approach that you think is most effective, to the shared leadership piece on this, which is the most difficult, the most engaged piece of this. And so we think about patient engagement at that direct care level, but there's two other important levels. There's the organizational design and governance level, where we invite patients in, not just to sit at the table, but to be meaningfully engaged in decisions about how organizations are delivering care and the focus and priorities they should have as organizations. And then beyond that, there's the system level, where we engage in policy making, where we ask the question, so how can we involve, engage, support patients and family members to make decisions about how our healthcare system evolves. Now, in our work, we focus on that middle level because I think that's the level that has received the least amount of attention. So how do we engage patients and family members to be a meaningful part of quality initiatives, of committees, decision making within healthcare organizations and across the network of organizations that deliver care in particular communities? And we're going to explore two examples of that in the work today to really understand what the dynamic is on this. And a lot of the work that's come out lately, which I think has been very helpful, has been really toolkits, really a series of opportunities for people to see the kinds of checklists, the kinds of aids that can be useful in developing initiatives in local environments. But we wanted to add something to that, which was to understand the context, the evolution of efforts to create effective patient engagement at the organizational design and delivery level. And the Naylor Task Force asked us to think about what the strategies and approaches were that would be most effective. And we said, well, the critical thing on this from our review of successful organizations and successful networks in doing patient engagement is that it's not just a question of identifying, recruiting individuals who can serve on various committees, task force, quality improvement teams, and so forth. It's creating an environment in which this is seen as an expected, normal way of working. And so when we went to Augusta University Health System in Georgia, they said that the critical issue when they were making a big decision was that the senior leaders would turn around if they hadn't already heard it and say, well, what do the patients and families say about this decision? Where do they want us to go? And it's that sort of creating that environment that marks the difference between organizations that have a nominal approach to patient engagement and organizations that see this as a critical, value-added step in moving forward. So we see this echoing the Carmen framework as engagement-capable environments are environments in which engagement happens at all those three levels, the individual level, the organizational level, and the policy level. And we've used this slide quite a bit, it's in the book, as sort of key components of what that looks like at an organizational level. And that engagement-capable environments are environments in which, first of all, there's a deliberate, well-planned effort to recruit patients who reflect the community in which you're delivering care. Not the ones that are easiest to work with, the ones that are most convenient, the ones that represent people who look like us. It's the people who represent the other parts of that patient group who need to be involved, who have different needs, and sometimes have difficulty expressing that in a way that's easy for others to hear. But it's not just about engaging and recruiting patients, because if you don't prepare the organization and help them work with patients, help them see the value, help them experience what it looks like in a true engagement fashion, then it's all for naught. And you're just turning people off, both staff and patients. So we think there needs to be a strong effort to engage patients and engage staff to understand how patients can make a contribution in moving forward. And then lastly, none of this happens without strong leadership. People are looking for leaders, they're looking for the signs, they're looking for behaviors that really reflect that this is important. So people who say, yes, let's recruit patients, but then don't reflect that in their own actions and their own decisions, are really sending a mixed message, and I think that's what we see in many places now. We're saying, yes, we're into patient engagement, but it's not really deeply rooted in the organizational culture. So ensuring leadership support, ensuring strategic focus, reinforcing that on a daily basis in the behaviors of leaders is critical in moving forward. So that's the framework that we're working with, and as I said, we went out and we looked at cases in England, in Canada, in the United States. We really drilled down on this, trying to understand what were the key components of the strategies and experience that might inform others who ask, how do we get engaged in this journey? What's the next step? What do we need to do to engage patients? So I'm going to turn this over to Patty, who's going to talk about the experience at the McGill University Health Center. Then Petrina will talk, and we'll come back and say, so what's next? How do we build on this moving forward?
Before I get started, I want to ask a quick question because I noticed that I was one of the people that in my organization was funded by CFHI as part of the patient engagement projects, but I see Esther Green here in the audience, and she was in the first cohort of funding as well. So just a quick show of hands. I'm curious to know how many of you have been involved, have been supported by CFHI activities to further your work in patient engagement, whether that's been through patient engagement projects, through the ACE Collaborative, Acute Care for the Elderly, through Family Presence Collaborative, any organizations? Okay, so check out their website. There are incredible opportunities to support the work that you're doing. In 2010, fresh off the Harkness Fellowship that I did in the United States, and as the Chief Nursing Officer at the McGill University Health Center, I launched a new initiative, a program aimed at building organizational capacity for quality improvement that would engage frontline caregivers, and I really mean directly the people providing care in inpatient services, and patients. At the time, we had just begun the largest healthcare redevelopment project in Canada. We were consolidating 6 hospitals onto 3 campuses, including the construction of a new 500-bed facility. The move, which involved reducing the total number of inpatient beds and outpatient activity, prompted us as senior leaders to rethink how care processes were going to be organized and how they needed to be redesigned in light of that new reality. Also, concerned with low morale, particularly amongst nursing staff, I knew that we needed to engage the hearts and minds of our frontline bedside caregivers. And I also believed that they had enormous untapped talents They didn't have skills in quality improvement, but they knew where the system was not working. And they spent enormous amounts of time in workarounds trying to fix our broken system at the clinical care interface. With enough funding from CFHI and the Newton Foundation, we launched the Transforming Care at the Bedside initiative, empowering both bedside practitioners and patients. I'll refer to them as patient advisors, but these are people who are current patients in our organization, and learning how to co-design changes that would improve outcomes. Designed by the Institute for Healthcare Improvement and initially tested in 13 hospitals in the U.S., Transforming Care at the Bedside engages the hearts and minds of frontline staff to lead quality improvement using rapid cycle improvement processes. When I did my Harkness Fellowship, one of the 3 case studies that I did was at Theta Care, which was one of those original 13 hospitals who were testing out the blueprint for TCAP. TCAP has 5 pillars: safe and reliable care, patient and family-centered care, teamwork, value-added care processes, and transformational leadership. But at the MUHC, our innovation, based on our beliefs and our experiences in working with patients, because this was not the first initiative in patient engagement in our organization, we really believed that we had to stop trying to reinvent the wheel by using the same faces and the same voices at the table, that we fundamentally needed to listen to the people who received care to know how to effectively and efficiently improve service. And Transforming Care at the Bedside engages staff and patient advisors in our iteration to co-design new care processes. We had 3 main objectives. The first was to understand care through the eyes of patients and families and to improve their experience of care. So that involved a new deep dive and actually took us into the world of measurement as well, because we only had one set of data, really, and that was a patient satisfaction survey that we always scored very high in the province, and none of us really believed that it provided any valuable information at all. And so we brought in the HCAHPS measure from the US, which is now, we have the Canadian version of that, the Canadian Patient Experiences Survey. Our second objective was to partner with patients and families and the care providers to redesign care that would better respond to patient needs. And third was to increase RN time in direct care and to decrease a lot of that wasted non-value-add work. We rolled out 4 consecutive implementation waves between 2010 and 2014 on inpatient units, in ERs, in ORs, and in dialysis. Each wave consisted of structured learning modules of approximately 10 weeks each, workshops combined with hands-on learning 1 day a week at the start of every module, focused on developing skills in 4 areas. Still in this one. Rapid cycle improvement processes including PDSA, Lean 5S methods, a patient experience of care bundle that we created that really combined 3 different interventions, whiteboards at the bedside, therapeutic questions, and hourly intentional rounding. And the 4th module was focused on process mapping to improve admission and discharge processes. Guided by the principle, nothing about me without me, patients were included from the very beginning in the redesign work. Each unit had 2 advisors embedded on the team, and we paid for the release time, 1 day a week throughout the entire rollout. And each rollout varied in length, anywhere from 2 years to as short as 7 months. So we paid for the release time of 2 RNs, a care attendant, and a unit clerk. Every week, this core group of staff and patient advisors met for a full day, identifying the problems in care delivery that they wanted to address, and then conducting tests of change, adapting, adopting, or abandoning ideas as they went. Patient advisors assumed leadership in context with the inpatients, describing the TCAP aims, co-planning tests of change, and obtaining feedback from patients and families on the changes that were being implemented. The patients were on the evaluation team, helping us apply for grants and overseeing all measurements. And then they co-presented the findings locally and internationally. Our evaluation approach included organizational level and unit level data, measuring time in direct care and value-added care processes. We never had information about that before. We just kind of had hunches about how a nurse's time was spent This time we got real measurements using personal digital assist devices. We looked at patient experience of care. Patient engagement process was measured through multiple focus groups held across the 4 years. And we had multiple measures of quality of care. But knowing full well that staff experience and work satisfaction drives patient experience, this initiative put decision-making about changes needed into the hands of direct caregivers. We then tracked impacts on multiple measures of work satisfaction, and at the unit level, the clinical staff learned how to do frequent pre- and post measures with their PDSAs. So in terms of outcomes, patient outcomes were tracked over 4 years, and they included a 20% increase in responsiveness of care. Patient satisfaction doubled with the introduction of a new interprofessional joint admission process in mental health, reducing the admission time from 4.2 hours that spread over 7 days to 1 hour. We saw a significant drop in C. difficile and VR infections. The bedside whiteboards improved two-way communication between the patients, families, and staff. Intentional comfort rounding reduced all bell use and improved patient satisfaction. And multiple new educational materials were developed by patients themselves for patients. In terms of staff outcomes, 45% of the clinical staff across the 6 hospitals gained new quality improvement competencies. We saw an 8% increase in registered nurse direct time in bedside care, a significant, primarily due to the removal of a lot of that non-value-added activity by teaching them Lean 5S and learning how to do waste walks. In one area, in one of the hospitals, they created a quiet zone for nurses that led to a 50% reduction in medication interruptions and a 60% reduction in medication transcription errors. And we saw statistically significant improvements on 5 different measures of team effectiveness. And turnover and overtime rates were statistically significantly reduced as well. And hands across the board, all hands down, every single nurse on all of the units and the care attendants and the unit clerks and the physicians said we should have patient advisors on all of our units. Briefly, in terms of organizational outcomes, spread and sustainability was a major focus from the beginning, and thus we were rolling this out over a multi-year period. So obviously, one of the major outcomes was a greater capacity to lead systematic quality improvement across our 6 hospitals. We obtained $1 million in grants from CFHI, CIHR, Maxwell Foundation, Newton, and Montreal General Hospital Foundations, and we invested $1.6 million internally. We were recognized with 2 leading practices by Accreditation Canada, one for the program itself and the other specifically for that new interprofessional admission process in mental health. We saw $3,000 of savings per unit of materials returned to biomed just because of learning the skills with waste walks and 5S. We accelerated gains on multiple other corporate priorities at the same time. We improved relationships enormously with the nurses union. And we, as a result of this, just as one initiative, had 38 new highly skilled patient advisors. We now have well over 150 of them, but this was our early starting point. And what subsequently it really led to was the development, the commitments internally to create corporate infrastructure to support patient engagement work throughout the organization with new, very clear requirements and standards across all major programs for having patient advisors embedded within all of their quality improvement work. The key elements of our success. Number 1 was courageous, cohesive leadership at all levels. Who walked the talk? A large range of leadership actions were used to support co-design efforts. Executive rounds were held at regular interviews intervals on the TCAP units. Executive leaders provided on-the-spot feedback as they listened to the teams give the report. And interestingly, most of the frontline care providers had never even met these executives in the organization. They'd seen photos of the CEO. I was a little bit more familiar because I moved throughout the organization a lot more, but most of the executives were completely unknown to the frontline care providers. Regular senior leadership presence throughout this, and supporting the managers at the middle level was really critical. We saw the difference between those areas where the leaders were present and those who were not. Ongoing coaching support to the project lead, local champions, and the implementation team were critical. We needed to remove the barriers and to resource additionally when they ran into problems. And regular meetings were held with bedside caregivers and patient advisors to review the challenges and see how we needed to reach it. Extensive stakeholder engagement was worth its weight in gold, not just at the beginning, but particularly as we moved to the spread plan. Recruitment of the patient advisors with clear roles and responsibilities. Creation of structured and mutual learning environments was key. All of the learning that occurred with the frontline caregivers, the patient advisors were there. They did this jointly, so everybody was learning it at the same time. We put coaching and facilitation support in place. The continuous feedback loops around data and measurement was a very interesting journey. I pretty well knew that most frontline practitioners were not too interested in the administrative data that we looked at the corporate level. But we saw that big time when we went there. Most of them had no idea really how they were performing, except on some clinical measures like pressure ulcers, falls, and that. So what we really did was teach them how to do local measurements that were meaningful to them. That stuck. That was really important. And then we said, you need to post this every single week as you're doing your tests of change. And in public places, nothing back in the back rooms, out where everybody could see. And resourcing was critical, protected release time. That was probably our most important investment, so that those practitioners would really have time to and relentless communication of results. And in closing, I think this quote from the president of our patients could be best illustrates how we felt. Thank you for giving us this project. We're discovering our strengths and we're working together. Who would have thought this would be possible? Petrina McGrath will be talking to you about their experiences at the Saskatoon Health Region.
Good morning, everyone. Thank you for the opportunity to be here and to share our journey of patient engagement and partnership. I'm going to be speaking about the Saskatoon Health Region, but also about the province of Saskatchewan, because we really focus very strongly on thinking and acting as one, and so many of our processes are intertwined here. Just to give you some context, Saskatoon Health Region is the largest health region in Saskatchewan. We service about 336,000 patients, and we have 100 different communities, villages, towns, and cities and First Nations communities that we service in our region. We're the largest employer in the province as well. One of the first things that really started our journey in the province and really was a key significant for Saskatchewan was our Patient First review that happened in 2009. So this was a commissioned review that really brought the faces and the voices of patients and families across the province into the discussions of leaders at all levels. It really was critical and I was saying last night as we were out, I still go back to that review quite often and say, are we there yet? It really helped say, we'll know we're there when, and gave some really concrete examples of what our patients and families were telling us they wanted. What we learned in that is that we had work to do around improving the experience, we had work on system performance, and really we had work around leadership, really how to lead the system that was partnering with patients and families. That our patient first had to be embedded as a core value in our system, and that in order to do that, we had to work cohesively. One of the things that really stood out for me in that review is patients and families said, these artificial boundaries we have don't mean anything to us. So when I drive down Highway 11, I don't think, I've just crossed over Saskatoon Health Region and now I'm in Regina Health Region. I just want to know that the services are there and that they're consistent. It doesn't matter which hospital I go to or which service I go to. The other thing, and building really on what Patty talked about, is it really interviewed frontline care providers, and really the review talked about that chronic care providers must be empowered to deliver patient family-centered care. So those, when I think about it, it's really a shifting of a mindset that says the most value added to a patient and family is really that interaction between those clinicians and the staff that provide service. And every other role outside of that really justifies itself on how they enable that interaction and that work to happen, how they remove those barriers, how they ensure the training, the support, the supplies, all of those things are there to help those clinicians work. And that's a really important piece that we continue to work through. At the province, we have a structure of patient-family-centered care, really came to in about 2010, and really I'd say the last 2 or 3 years, it really has strengthened. So we have patient-family advisors at that level, we have CEOs on that oversight, and it has a direct link to our deputy minister and our CEOs across the province. It really sets consistent standard expectations around, so open presence. So we saw lots of individual organizations like Saskatoon who've been working on visiting hours and removing visiting policies, but this group said, really, we don't want that to happen just when we're in Saskatoon, we want that to happen in Moose Jaw Hospital. It's an expectation, it's now a standard of care. So this group really sets those expectations and standards, and then locally with our local units and local patient-family advisors, they work on the how to make it happen. That's where the frontline staff, physicians and patient advisors come together to say, on this unit, what are the things that we need to think about? But we report up and link to that overall. The other thing that we're just working through is patients and families as members of the team in interprofessional rounds. Again, it's set out as an expectation for the whole province in every area, but locally those teams are looking at what the current state is, what are the processes to do that. At Saskatoon Health Region, we started with an advisory committee in 2007. And when I went out to Saskatoon in about 2011, one of the things that I was so impressed about or really excited me is that they didn't worry too much around getting it perfect. They just started to bring patients and families to the table. So when I arrived, patients and families were at the table in many decision-making areas. They were guiding, and it wasn't perfect, but we were learning as we go. We didn't try to worry about getting it perfect at first, and so we stumbled a lot and we learned together. And I must say, well, today we're talking about what do the leaders do to create those engagement-rich environments. I must say, as a leader, I have many patient-family advisors that are really mentors to me. They challenge me, they're thought partners with me, and they help mentor me in trying to push to the next level. The framework that Ross put out, the Carmen framework, one of the things we've started to do in using that is actually sit down and say, okay, we're about to lead this initiative on safety. Where do we want to push ourselves to next? Where do we think we are right now in the organization? What would it look like if we were moving towards that far right in that organization, that co-leadership partnership? What would that have to be? What would we have to be doing? And we work it out together. Now, sometimes, I must say, I've had times where we've tried it and we're frustrated. The patient family advisor is frustrated. I'm frustrated. We're trying to figure it out. But the key thing is it's about movement and about having those challenging conversations and being committed to learning as we go. And I think our advisors are so amazing in being patient with us and yet constantly pushing us as well. We have 18 patient family advisory councils, and largely they started in the acute care areas, critical care and emerge, etc. But now we have extended into home care. We have outpatient addictions, HIV, patient family councils, and also our Aboriginal Métis patient family councils is really helping us learn how to engage in a different way with some of our unique communities that we serve. We have structures and processes in place, but one of the things that's been really important is I may lead the strategy as the lead in Saskatoon Health Region, but every one of us on our senior team have a role and responsibility to be asking those questions, just as Ross identified, is how, when I lead this project, are patients and families engaged and involved in informing, and it really is everybody's business, not any one individual's work. We have 100 patient family advisors. In the last couple of years, I think the push is really where we've been pushing ourselves is involved in board quality and safety committees, review of critical incidents, quality of care committees. Those are ones that, while we're doing great work at the local level and really having patients and families involved in local team design and quality improvement work, there was this hesitancy at the higher levels around, oh, you know, this is really still messy. Do we want to get our act together first before we bring patients and families? And again, we had to keep pushing and do that. And I think one of the things that, again, is just bringing them to the table and together learning through how do we be, you know, create a safe space and be able to learn from each other. So we're seeing now patient family advisors on interview committees for frontline manager roles, for charge nurses. Who are the next charge nurses on this unit? What are those competencies and capabilities we're looking for, and how do patients and families shape that? We also have had some great success working with our academic partners where students are next leaders. Actually have a patient and family member that they follow, they are mentored by, and they follow them through their appointments and through their journey to learn and that we're seeing some amazing work happening there. In 2011, I would say it was another critical point for us. We were building a children's hospital in Saskatchewan, and we were going along a very traditional design approach, and then we paused and we started our work at Lean Journey, and in that Lean Journey, we started to bring patients and families in co-design. And I would say those were amazing, amazing events, week-long events. And if you look at some of the pictures up here, you can probably look at that and you can't tell necessarily who the surgeon is, who the patient and family advisors are, who the OR tech is, or who the manager is. One of the things that these co-designed was really create crucial conversations about how we were going to design our system, creating principles together, and then testing those designs against those principles. And what I saw in those conversations over the week as we designed was our patients and families pushing our clinicians to places that we hadn't thought about, and really being able to facilitate through some of those very uncomfortable conversations. And the design of our building is quite different because of that. We now have rooms where women will labor, deliver, recover, all in the same room. And that came from many conversations around what that was important. They're just like magic in those conversations and the outcome of those. We've gone on to use that to design our safety system, models of care, and again, really engaging in a way that we are learning together and building that trust. So a couple reflections. There's many more pieces of work I could talk about, but some of the reflections I had as I think about our journey is that this is a journey. It's not a destination. And things that we did 4 years ago that we thought we were just rocking it. We were amazing. And now we look back and go, oh my gosh, like we were so, we didn't even get close to good partnership at that point. So it is that constantly pushing and challenging. It's responsible of every leader. Every leader has a responsibility to engage patients and families on a regular basis to understand. It's a privilege to serve in our health system, and it's so important for us to do that, to really make sure that we're hearing that voice. I think one of the things I learned, I can never assume I know what the patients or families need. Never assume. When I try to assume, I'm always wrong. So really that importance of being out there and engaging large numbers of voices in that and trying different ways. The other piece for me as a leader, and I think for many of my colleague Jackie Mann, who's leading our children's hospital, will say that embracing the tension is so important. And I would actually say if you're working through things with patient families, if there isn't tension, then we aren't really changing. We're actually not moving. And so that tension is really important. It's important to be healthy tension, but it's so important to keep that tension and keep moving to the next level. I think it's really about co-production now. I think that's really our next piece of work in many ways, at the local direct care level, all the way up to the policy level. And really building on what Patty talked about around the importance of walking this journey and supporting our patients, not only our patients and families, but our clinicians, our physicians, our nurses, our frontline support areas. They need to know that as we change and push the system, that their needs are met and that they're safe to practice the way that they feel is important. So really supporting them as much as possible is really important to sustainability. One thing we've really found is that point of care manager or supervisor is a critical role. And we're just doing some really important work to really look at how much time they spend or have the ability to spend in the practice setting, talking to patients and families, and that's a real redesign work that we're doing. The other thing that I think keeps me up at night, or is the part of that's really the most challenging of this journey for us still to do, is really making sure that we're including the voices of everyone, and including those that are most vulnerable. In our advisory committees, it's easy to get for some individuals to get to meetings, to come into the healthcare system, to come onto the unit to do that, but there are many who can't. And one of the areas I think we're just starting to learn about and get stronger in is our work with our Aboriginal and Métis community. I think that is an area where you really need to build the trust and create trust with that community. And in order to create trust, we need to learn and participate in their ceremonies. We need to, once we started to do that, once we started to engage in that way and learn from them, then they started to be willing to advise us, to give us their knowledge and their wisdom, and that has helped us incredibly, and we still have a long ways to go, but that's just one community. We have work to do with many other different communities in our organization to really do that. That takes time, and it's really important work if we're really going to represent everybody.
Thanks, Petrina and Patty, for those wonderful sort of descriptions and analyses of your experience. So I'm just going to take a few minutes to sort of paint a picture of where we are and where we're going here, and then we'll open it up for dialogue. So this is the current framework. As you can see, it's very static. It doesn't really represent the flows between these two levels, but if you listen to the descriptions of both the Saskatoon and McGill University case studies, you start to hear the ways in which engagement of patients in these initiatives within the organization starts to spill over into the way in which care is designed, spill over implicitly into the relationships that clinicians have with patients, and influence the policy and governance work within that organization. So I think we see this sort of as an ongoing dynamic, and working at all three levels has benefits at different levels. So where are we? Well, the 21st century is here, although many of us are still working as if it's the middle of the 20th century. But I think patient engagement aligns with a number of critical trends that we see in the healthcare system, and I just want to mention a few of these quickly. One of them is this issue about digital resources for both clinicians and citizens, the way in which that's changing daily work. Second is the incorporation of social and behavioral insights into evidence-based practice. And the third is this broader interest, this broader focus on health strategies to reduce the burden of disease. So in the graphic on the right, something I've just come across recently, which is a report by Deloitte in the US, looking at what consumers want from healthcare. And it comes in 4 buckets. They want to be digitally connected to manage their healthcare. They want convenience in their use of care. They want economically rational coverage and care choices, which is a particularly American concern. And then they want personalization. They want their care to focus on who they are, what they need, not to be some part of a larger bucket of patients or consumers receiving care. And I think this really feeds into the issues that I see moving forward. So we live in a time of rapid change, and both patients, or citizens really, and clinicians are becoming more engaged with digital tools. And it's changing the way in which people work, and it's changing the way in which clinicians and patients relate to each other on an ongoing basis. And we're just seeing the opening to this. And despite the challenge of interoperability across electronic health records in our system, despite the barriers that are put up by privacy concerns, I think we're going to see a rapid change in the next 10 years in the way in which clinicians engage with e-patients. As patients want to share the data they have on their health conditions that they've collected in monitoring their own vital signs. And then they want to learn from their experience in healthcare organizations, getting access to their records, and then having a different conversation, a broader conversation with their clinicians. I think that will change patient engagement in a meaningful way. And we saw an example of that in one of our case studies, which I won't go into in detail, but this great work supported by the Change Foundation, Northumberland Community Partnership, the PATH Project, really giving patients the tools, the courage, the responsibility to become engaged in a different way with clinicians in their community, with each other, to change the way in which they thought about their health and their health care. The second, I think, important dynamic here is the dynamic around research and practice. So we've talked a lot about involving patients in terms of redesigning care, and we have a case study in the book about work at Cincinnati Children's in collaboration with pediatric centers across the United States now, where they have put together clinicians and researchers with patients and families to redesign care and to rewrite the research on providing care for children with inflammatory bowel disease, a difficult, lifelong issue for these children moving forward. And the interesting story we were told, talking to the patients and to the researchers, they said, you know, this was like two different worlds. We were talking to a group of teenagers about their experience with inflammatory bowel disease, and the teenagers said to us, we know you know what the evidence is, but we don't want to be IBD patients, we want to be teenagers. We want to live our life with our friends, right, the way in which they're living. And so how do we create an ongoing lifestyle, an ongoing management of this disease in a way that respects both the evidence and the desire of people to live as teenagers? That's been a huge breakthrough there. And now they're dealing with a majority of IBD patients across these centers, and they've seen remission rates for these patients in this difficult disease move from 55% to 79%. Reduced of readmissions from 59% to 79%. If this was a drug, this was a new medication, right? Everybody would leap on this as if it was the hottest thing available. So we have to ask the question now, how does the patient engagement influence research and practice? And lastly, in this issue, as you hear this discussion here, we've moved forward from just talking about the redesign of healthcare to the redesign of strategies for healthy living. And I think one still hidden but potential opportunity for us is to move from this idea of now working with individuals in terms of their health care and the health care they receive, to working towards them to live lives as fully as they can, regardless of the conditions and the challenges they face. And again, another case study in the book, a fascinating story about this wonderful team in northern London, in Islington, at Whittington Health, that has won awards for their ability to link COPD care in the hospital to primary care in the community and to take advantage of all the resources available to do that. So we are in this wonderful era. We haven't mapped out all the steps forward, but I think it offers many opportunities. I want to thank the panelists. I want to thank the many contributors to this book. In addition to the cases, we have an overview chapter, and we have a wonderful introduction by Professor Glenn Robert from King's College London, who's one of the leaders in co-design work, and then two afterwards, one by Vincent Duvez from Montreal, who's been deeply involved in patient partnership, patient co-design in Montreal, and then Jim Conway, the former COO and IHI senior fellow who worked at Dana-Farber. So thank you, and turn it over to Maria to start to moderate the questions.
So thank you, Ross, Patty, and Petrina, and over to you. Questions or comments? We welcome them. Just a reminder to press the button so your mic is on. Please go ahead.
So I wanted to pick up on your sort of "Are we there yet?" theme in the Saskatchewan presentation. A few years ago, Leslie Thompson invited a small group of Eastern Patients Canada to go and spend a few days with her meeting people at Kingston General and sort of learning about what they'd done. And we met everyone from board members to patients to housekeepers to frontline staff, physicians, nurses, and the works. And one of the questions we asked at the end of the meeting, of each meeting, was the question about, sort of, have you accomplished what you were looking to accomplish yet? How close to it are you? And we were really struck by the discrepancy between the responses we got from the frontline staff versus and the professionals versus the patients. The patients felt they just scratched the surface. They were maybe 10% of the way there. Whereas the frontline staff came back and said, we've we've killed a monster here. We're 90% of the way there. So I'd be interested in your thoughts just on those different perspectives and the different expectations. I mean, going back, I guess, Ross, to your sort of original framework with the three parties, leadership, patients, and frontline staff, just the different expectations of the main groupings here that are involved in this journey.
I think Petrina and Patty can really address that.
Yeah, I would say that I actually think there's always going to be a bit of that, because I actually think our patients and families, as we might set out something, we get to it or close to it, and then we're on to what's the next level. So I do think that especially when we're changing care processes and design, there is so much work to do in that, and so many elements that when staff achieve, when you've achieved something in a year, it seems like amazing, and it often is, it is amazing. But I think for those patients and families, it's just one piece of a bigger journey that we need to do. So your lens and your visual as well as a patient. It's interesting, my daughter has just become a patient in our system, and as I walk that journey with her, we see all the elements of that journey, all the way from the ambulatory office, all the way to coming out of being admitted into a hospital. The staff are working on some little piece of it in one part, but often it's the in-between, and that's the that linkage work that I think is still probably, I know in our organization still, that's where we need even more change to happen. I don't know if that answers that question.
Just a quick addition to that. The literature for decades has shown the discrepancy between how we as healthcare professionals think we're doing. We always rate ourselves better than patients have. That's been there. I can remember that from articles in the 80s. I think we need to shift our focus, and both are realities, and I think that particularly when I think of the work that we've done with our frontline care providers, and when I listen to Petrina's story, it is a huge movement that we've been able to develop competencies where they feel they can be far more in control of being able to change the system. That's significant work, and we need to give it its due. But every single time patients tell us we're just barely beginning the journey. And it doesn't matter what form I've been in what organization, because I've been working with CFHI now for about almost 3 years, and we've been supporting teams across the country. And the one comment that every single patient advisor says is, why does it take so long to make the changes? The sense of frustration, that one sentence I have heard every single organization, the advisors say. So I think we just need to recognize we're making some progress, but instead of paying attention to and being pleased with that, we need to listen more and shift the focus to what the patients are really saying. Because they rate it far lower and the journey much longer, and that's really, I think, this is about shifting the attention and to really listening to their stories more so we know really, truly how much further we have to go in this.
Any additional questions or comments? Teresa?
Yeah, very interesting work. What I was curious is how many of these examples are a win-win, where you save enough money in efficiencies that you get improvement and lower costs, as opposed to having to invest more for better outcomes. And the other one, which worries me in a lot of the American literature I've read, is that their version of saving money is to shift all kinds of responsibility to patients and tell patients to manage everything themselves so that they don't have to do it. I mean, we've been trying to look at the patient, some research at the patient level, which is not simply funded these days because everybody's at the meso macro level. But how much can you make the case that you'll save money and get better results?
So just very briefly, because we were funded by multiple grants, we were able to do a lot of measurement. We did different measures in each of the implementation phases, but we were able to really track what was true savings in terms of dark green dollars and light green dollars. The difficulty, of course, in the Canadian healthcare system is that what it means is if you've improved your efficiencies, it just means that people can do more of something else. It's not, so finance would always say, well, where's the money back, Patty? So when I said we had a statistically significant decrease in turnover, that represents about 55,000 per RN. So all of those, we've been able to crunch some of the numbers and quantify. So there are measurable differences. The reality is that it's not like you give money away from all these areas we've implemented, but there's no question we've improved efficiency.
And I think too, the case study that's in the book is looking at the Chronic Care Collaborative Network that was started at Cincinnati Children's, excuse me. They're actually developing their business case now, but from understanding, talking to Dr. Peter McGrath and Justin, the physician and parent co-leads, it's tremendous, and they're just trying to put the dollar value on actually connecting a database like Patients Like Me with the electronic health record with the research database, and that huge increase in remission rates that Ross showed is no change in medical care, no additional expenses, but huge improvements in terms of people's health and reductions in existing services. So they're in that process right now, but it's looking very promising.
Mine is on, it seems. Thanks a lot. I was just wondering, obviously, Saskatoon and McGill's projects are likely the more sort of mature patient advisory committee usage across the country. What did you get the sense of in terms of the adoption and maturity level of these kind of advisory committees across the country? Were there places where similar things were going on, or are there a lot of places where there are holes?
So our intention wasn't really to do a survey and understand that. Our intention was to identify leading places and then look at their experience that might be potential models for others. So it's a really good question. I think it's something that needs to be done moving forward.
I think there has been some work done by the Change Foundation and looking at kind of what do patient family advisory committees, what kind of decisions or issues are discussed there, what kind of decisions are made, and I think there is work underway. Certainly wasn't within the scope of this work, but to understand, is there a relationship between sort of the maturity of, say, a patient family advisory council or patient family advisors being present in an organization and the kind of influence that they have on decisions, and certainly, that sense of moving forward. These are organizations where they had patient and family members, and their input and their experience on committees and the patient experience survey was very much connected to the improvement work of the organization. We know that's not the case in every organization, but that's where we want to be moving, right? Matt is going to kick me up the stage.
Thank you to our speakers. A great talk this morning. I appreciate your time. Season for Breakfast with the Chiefs. Our next breakfast was to be in January, but it's been pushed to February 1st, and it will be Omar Ishrak, the CEO and Chairman of Petrina. Thank you very much, and as mentioned, the speakers will be hanging out for a little bit to sign any folks or answer any additional questions. Thank you.
Well,